Hello, my name is Dr. Kiel. I'm a professor of both emergency medicine and sports medicine at the University of Florida College of Medicine in Jacksonville, Florida, here in the US. And I'm just going to quickly present my abstract on the epidemiology of patients presenting with gout to our large county hospital. So the idea is that gout's very common. We were also looking at septic arthritis, but primarily gout. And what we wanted to do was sort of characterize the epidemiology, clinical, and diagnostic findings of patients that presented to our ED with either gout or septic arthritis. So we had an IRB approved study at a large county, urban county hospital. It was a retrospective study of adult patients between January of 16 and December of 18 with a primary diagnosis of gout. Ultimately, we decided to exclude septic arthritis because we just didn't have enough patients with that diagnosis, and then we did descriptive and summary statistics on all of the variables. So we started with 22,000 patients who presented with monoarticular joint pain and ultimately narrowed that down to 95 patients who were included. The exclusion was based on age, repeat visits, and primarily patients who did not have a primary diagnosis of gout on their coding. The average age was 56. They were primarily male and African American, and most commonly they were diabetic. The great toe was most commonly affected. They primarily complained of pain and swelling and had tenderness and edema, so the similar findings on physical exam. About half had x-rays, and of those who did, only about 18% had radiographic findings of gout. And only 10% of those 95 patients had an arthrocentesis, but when it was performed, it was likely to show monosodium urate crystals. And the vast majority were prescribed a non-opiate analgesic and rarely steroids. So what did our study tell us? What did we learn? Well, gout can present atypically in the ED. It's fairly uncommon as a percentage of patients presenting with a chief complaint of joint pain. It was often diagnosed and treated empirically and not necessarily with arthrocentesis or even radiography. High use of non-opioid and opioid analgesics, and in the future we should sort of explore the role of using physical exam and history as a diagnostic metric as opposed to the more objective measurements of arthrocentesis and radiographic assessment and whether that's accurate, and then focusing on non-opiate analgesic strategies for pain relief